Hi everyone, this is the recording for online NFDN 2003 for unit number 3, the management of altered oxygenation. So what are some factors that can increase one's risk for altered oxygenation? There are a couple different factors that can increase the risk. The first one being environmental. So this refers to the amount of air or the quality of the air that you breathe. So such things as secondhand or third-hand smoke can be a risk factor for altered oxygenation, or generally poor air quality. So this is in areas that have large amounts of air pollution, or potentially in a fire smoke area. Like we did have here in this last summer, we did have quite a fair bit of altered air quality due to the fires around us. So secondhand smoke is inhaling the smoke off of a cigarette or the smoke exhaled from an individual who is smoking beside you or around you, whereas third-hand smoke is inhaling the smoke vapors off of someone who has smoked not around you. So this is smoke that has been integrated or infused into the patient's clothing or into the patient's household around. They may not be directly smoking near you, but still those fumes and those toxins are seeped into the areas that are around them. So some behavioral factors. So again, smoking is a big risk factor. Bed rest or sedentary lifestyle, so just not using those full lung capacity. Developmental or psychological factors, so asthma, diabetes, heart disease plays a big role in the effects of your lungs. Same as renal disease, also plays a big role in the effects of your lungs. COPD goes along with asthma, and then pneumonia. We will talk about asthma, COPD, and pneumonia later on in these slides as well. So as a nurse, what is your responsibility if we're caring for someone who has altered oxygenation? First thing we always do is assess. So we always assess the patient and check to see why they have some abnormalities or what those abnormalities maybe are. We need to do this proper assessment in order to formulate our nursing diagnoses and our goals for the interventions. This assessment includes if the patient has a cough, if they're feeling short of breath, if they have any chest pain, if they have any history of respiratory illnesses or infections, or their self-care history. So what do they do to help prevent respiratory illnesses? If we do identify any abnormalities, we need to intervene when we need to treat those abnormalities. Then we need to teach. A lot of risk factors are modifiable with appropriate teaching. Then, of course, we need to document. One of the common diagnostic tests for altered oxygenation is checking for a pulse oximetry. So pulse oximetry measures the rate and oxygen saturation in one's blood. The patient must have at least a systolic blood pressure of 90 millimoles per hemoglobin for this to be accurate. These tend to be inaccurate if the patient is wearing a dark colored nail polish. So we need to possibly remove that nail polish or use a different extremity if we are unable to obtain the pulse oximetry status through the nail polish. This can take up to 2 minutes to respond to therapy or a decline in patient status. So we always are making sure that we are assessing our patient, not just the numbers on the machine. We're also looking for something called the waveform. So that's on a pulse oximetry that looks like this. This is a little wave zigzag formation here, or on one that looks like this, similar to the ones that we have in lab. There's a little barcode that goes up and down. So we want to make sure that we have an equal rise and fall of that bar, or an equal up and down motion of this waveform. And that shows the patient's heart rate, and it also shows the connectivity of the pulse oximetry. So we need to make sure we have an appropriate connectivity in order to make sure that the values that we are seeing are appropriate. Another diagnostic test we perform is an arterial blood gas. So this is obtained through an arterial blood collection. This is not something that is in the nursing scope, so you need to have advanced training to do it. People who have advanced training to do this are physicians, respiratory therapists, and advanced care paramedics. So what does it measure? It measures the hydrogen ions, or the pH of your blood, partial pressure of carbon dioxide, or PCO2, which the normal range is 35 to 45 millimoles per hemoglobin. So the pH of the blood, the normal pH is 7.35 to 7.45. Partial pressure of oxygen, or PaO2. Normal range is 80 to 100 millimoles per hemoglobin. And then lastly, it measures the oxygen saturation, so the SaO2, which the normal range is 95 to 100. I hope you all know that. These values are then used to interpret and determine how well your lungs are able to move O2 into the blood and remove CO2 from the blood. As nurses, our responsibilities are just to monitor the collection site for bleeding. This is an arterial blood gas collection, so this blood sample is obtained from an artery, so there is a higher chance or a higher risk of bleeding. So we need to ensure that pressure is held for at least 5 minutes after the collection to ensure that bleeding has stopped. A pulmonary function test is another diagnostic tool that we use. So this measures the lung volume, the amount of air that moves in and out of the lungs. It also measures the lung capacity, so how much air the lungs can hold. So in order to perform this, the client inhales into a tube or into a machine. There's a couple different ways to test for it. It's used as an ongoing test to monitor disease and lung conditions. So if a patient has asthma or COPD, this may be performed every year or every couple of years to see if their disease is progressing, or perhaps if their treatments are helping and aiding in their recovery. It is non-invasive, and as nurses, we just educate the clients on the test. Another common diagnostic is a chest X-ray. So it's used to diagnose the lungs fields, observe and diagnose the lung field for fluid infiltrates, such as pneumonia, masses, such as lung cancer, fractures, or pneumothorax, so a buildup of fluid or blood in the lung or in the pleural space. Is used to in both anterior, posterior, and lateral views, are used to obtain this proper imaging of the lungs to get the proper diagnostic field of vision. It can be completed at bedside in some facilities. The images are taken by specialized trained staff. As a nurse, we are responsible for positioning the patient, making sure they are in an upright manner to get the full field of lungs visual, transporting them to or from the X-ray department, and removing any obstructing jewelry. So any sort of metal we will have to remove, as the imaging will not be able to go through it. So in this photo here, we can see a very clear view of this patient's lungs. You can see the patient's heart here, their aorta, and their esophagus is going up here. So this is a very nice, very clear view of the patient's lungs. Next, we have something called a CT, or computed tomography. It provides a visualization in fine detail. Is used to help diagnose pneumonia, lung masses, suspected pulmonary emboli. So a CT is done in cross sections from the top down. So it's observing the lungs in a different plane that then X-ray is observing. So any of these dark white spots are consolidations. So these are abnormal spots. So these could be a lung mass, could be an emboli, or could be an area or an abscess. As a nurse, we are responsible for positioning the patient, transporting and organizing transport to and from the CT department, educating the patient on the test. So this test does take a little bit of time to complete. It takes a couple minutes. The test itself can be a little bit claustrophobic as well, and it can be quite loud. So we need to make sure that the patient is in an appropriate mind frame in order to lay still during this diagnostic procedure. If the patient moves or wiggles around, we will not get a clear image, and the imaging will have to be repeated. So if we fear or if we know that the patient is not going to be capable of laying still during this exam, we may perform or administer a mild sedation. But of course, this would have to be a physician's order, but we can't suggest it. Next, we have a sputum test. So this is used to determine what microorganisms are present and what antibiotics or treatment are used or appropriate. So we did talk about cultures already in Unit 2, specific to wound cultures, but every kind of culture that you obtain is going to test for the same thing. So it's going to test what kind of bacteria is growing in that cultured or in that collection, and then it's going to compare it to different antibiotics and see which one is appropriate for it. It can also be used to identify lung cancers. So it takes a closer look at the exact makeup of that sputum. We need to collect it in a sterile container, making sure that it does not get contaminated by any external force or any external surface. Typically, morning collections are preferred as it does create the biggest bacterial growth in the morning. Nurses, we are responsible for collection, education on proper collection, and transportation to and from lab. So in order to obtain a collection, we need to educate our patient on how to properly expel the sputum. And to properly expel the sputum, we need to instruct the patient to clear their nose and throat and to possibly rinse their mouth to decrease the contamination of the sputum. Then after taking a few breaths, we ask the patient to cough using their diaphragm and expellerate the sputum into a sterile container. The deeper the sputum, the better the collection, and those are typically obtained early in the morning. So another diagnostic test that may be performed is called a bronchoscopy. So this is where a tube or a camera is inserted into the trachea and the bronchi, and this is used to visualize any internal structures. It can be used to obtain fluid or sputum. It can be used to obtain a biopsy, remove a mucus plug, or remove any foreign bodies. As a nurse, we are responsible for administering sedation, monitoring sedation during and after the procedure, and educating the patient. Nasopharyngeal swabs. So these are the swabs that were used to diagnose or to determine if a patient had COVID-19. So I imagine that all of you have had at least one nasopharyngeal swab in your history. So it is part of the nursing scope to obtain a nasopharyngeal swab, and this is done by inserting a swab stick through the nair to obtain nasopharyngeal mucus. So it goes right to the back of the nose to obtain a mucus sample from back here. It is used to detect respiratory viruses only. And as nurses, we just perform the sample and then we educate. Okay, the next few slides are going to go over artificial airways and ventilation. One of the most common types of airways is called an oropharyngeal airway, or abbreviated to OPA. This is one of the simplest forms of airways, but it is required on a sedated or unconscious patient, so a patient without a gag reflex are the patients who are the most appropriate for this kind of airway. It is used to prevent the tongue from dislodging or displacing and obstructing the trachea. So it does come in multiple different sizes, ranging from infant to large adult. The size of OPA that is used is determined by the size of the patient's jaw area. So we take the tip of one OPA and measure it against the corner of their mouth up to the corner of the jaw, or the angle right below the ear. It should be the length of one of these OPAs. We then insert it upside down or curved side up until we get to the soft palate, flip it over, and then have it slide down over the top of the tongue. This phalange should sit and rest right at the patient's teeth or the patient's lips. It should not go into the mouth, and it should not have a large gape in between the patient's mouth or teeth and the phalange if it has a correct fit. These are great as you can provide alternative airways over top or alternative oxygenation methods over top. So you can put a mask over top of these, or you can use a non-rebreather or a bag valve mask as well on top of these. Up next, we have the nasopharyngeal airways. These are also called a nasal trumpet or an NPA. So they have a similar working mechanism to that of an OPA or an oral pharyngeal airway, as their main purpose is just to decrease that tongue displacement from blocking the trachea. But unlike the OPA, they can be used on conscious and semi-conscious patients, so patients who have an intact gag reflex. They also come in multiple different sizes, and the size is determined by the patient's frame or the patient's size. So measuring an OPA against the patient's nose and then down to the tip of their ear is the correct size. They are inserted through one nair using a water-based lubricant, inserting it bevel up and then doing a slight rotation of 180 degrees as the flange goes down. That flange then should rest against the patient's nair. These are not to be used on patients who have epistasis or a nosebleed, or any patient who we suspect facial trauma on. The next airway is called an endotracheal airway, which is probably the airway that you are all most familiar with. So these are airways that are used on patients who have a decreased level of consciousness or who are sedated and no longer able to breathe on their own. It does include a very high risk for infection and airway injury. It does require advanced training to insert, and they use something called with this kind of shape. This is called a laryngoscope, and it's a flashlight that shines a beam down on this curved blade that then lifts up the tongue in order to allow that tube to pass in through down to the trachea, so it does not go into the esophagus. It does require mechanical ventilation, so either that is completed through a machine or through ventilation through another person using a bag valve mask. They are typically for short-term use for less than 14 days. So as a nurse, what is our responsibility for a patient who has an endotracheal tube? We need to make sure that the patient is sedated. And while they're sedated, we need to monitor their vitals. We need to monitor their heart rate through an ECG or an electrocardiogram. We need to monitor the patient's input and output. And we need to ensure that that patient has IV access. After the endotracheal tube is inserted, we need to monitor for the positioning or assess the positioning and the conditioning of that tube. We need to do frequent respiratory and cardiac assessments. We need to suction of secretions. Patients with an endotracheal tube are no longer able to expellate their own secretions, so they do often require a fair bit of suctioning. A lot of times endotracheal tubes are made with an external suction device attached to them. So they are very handy and very nice. It keeps it in a nice sterile environment in order to obtain that suctioning of the sputum that has built up inside of the tube or down into the lungs and the bronchi. We'll talk about suctioning later on in this presentation as well. We need to monitor the patient's ventilation and sedation needs. We need to assess and change the endotracheal tube securement devices. We need to make sure that these ties are adequate and keeping clean. We need to provide oral care. Studies have found that patients who have appropriate oral care or receive appropriate oral care during endotracheal intubation greatly decreases their chance of an airway infection. And we need to monitor for medication reaction. These patients are usually on a fair bit of medications, sedatives and otherwise, so monitoring for those reactions. Next airway is tracheal, or a trach tube. These are used in patients who have oral tracheal damage or who have decreased level of consciousness or sedation. These again are a very high risk for infection and airway injury. So these are tubes that go through the neck into the trachea. They do bypass the oral airway. So straight through the neck into the trachea. They do require advanced training to insert. So this is not a nursing skill to insert a tracheostomy tube, but it is a nursing responsibility to manage a tracheostomy tube after it is inserted. A lot of times individuals with tracheostomy tubes require mechanical ventilation, but some patients will not require mechanical ventilation. It just depends on their level of consciousness. And these are for long term. These are typically used for more than 14 days. Some patients live with a tracheostomy tube for the remaining of their life, whereas some patients may be able to have the tracheostomy tube reversed or removed. What is our responsibility for a patient with a tracheostomy tube? Respiratory assessment. This is our big one. We do a lot of respiratory assessments with a patient with a tracheostomy tube, as we're always monitoring for the airway compromise, monitoring their level of consciousness and their vital signs. Assess and positioning and the condition of the tube. We want to make sure that this external canal stays external and resting against the neck. We don't want it out too far, meaning that the canal itself is not in the proper location, or we don't want it to slide into the patient as well. Again, meaning is not in the correct location. These patients often need help suctioning their secretions, which we'll talk about suctioning in a few minutes. Sometimes they do require oxygen. We need to monitor their oxygenation rates. We need to learn how to change and clean the cannulas. This is a lab skill and something that you will learn in lab. We need to assess and change the trach ties. So these ties need to be quite snug, not tight enough to cut off circulation to the patient's brain and to their head, but they need to be tight enough not to have an accidental dislodgement of this tube. So as you can see on this patient, they are fairly snug, but not snug enough to have compromised blood flow. And again, we need to provide oral care. So similar to an endotracheal tube, providing oral care to a patient who has a tracheal tube greatly decreases the risk for airway infections. So what are some unexpected outcomes of a tracheal airway? These tracheal airways can easily become dislodged. If you have a patient who has a dislodgement of their tracheal airway, we need to call for assistance right away, and we do not leave that patient's side. We can attempt to replace the old tracheostomy tube with a new spare tube of the same size. These are typically kept at the bedside. Prepare to mechanically ventilate the patient if any respiratory distress happens. So there should be a bag valve mask held or kept in around that patient who has a tracheostomy tube in the hospital. There typically is a little trach box that either sits immediately outside the patient's room or somewhere inside the patient's room if there's a patient with a tracheostomy tube. We may observe or assess a hard reddened area around the tracheostomy tube insertion site, and this can indicate infection. This is something that we need to report to our healthcare provider. We need to increase the frequency of our tube care, so washing and cleansing that tube a little bit more frequently, or remove that inner cannula and do more frequent cleaning and suctioning. Those securement tubes, we've previously talked about those. They keep the airway from moving in and out. So we need to observe that they are in the correct location. And any breakdown or any pressure areas from the tracheostomy tube. We may need to increase the frequency of our tube care, of our cleaning and maintaining the stoma, and make sure that the skin stays dry. So after we are cleaning it, we are making sure that we thoroughly dry the patient's skin underneath their tracheostomy tube to keep it dry and in appropriate condition. So now that we know about the different kinds of airways a patient can have, we're going to jump in and talk about the different kinds of ways that we can administer oxygen. So our first kind of way that we can administer oxygen is something called an oximizer. which is essentially the mustache form of a nasal prong. It's a specialty nasal cannula. The little mustache here is actually an oxygen reservoir. So it's where the oxygen can go from the tube, and it sits in here until the patient takes an inhale in. So no active air is getting blown into the patient's nostril like it would with a regular set of nasal cannulas. So oxygen is just sitting in this little cannula or this little reservoir waiting for the patient to take an inhale in. Because it does sit and wait, the oxygen, the patient gets a higher quality or higher content of oxygen per inhalated breath. Because of that, they require up to 75% oxygen flow rate. So if the patient was on 3 liters per minute via nasal prong, they would need approximately 1 liter per minute via oximizer, which is a significant reduction, especially if we get into the higher liters per minute. It can be cheaper just because it does require less oxygen. It is more comfortable. It does reduce a lot of anxiety, especially in the higher liters per minute. So a lot of patients can't tolerate or don't like the feeling of a simple mask over their face, as it does require a fair bit of, or does provide a fair bit of compromise on the patient's part. Some patients have difficulty sleeping. They are not able to eat or chew or drink appropriately as they have this mask over top of their face. So these oximizers provide a lot more comfort for the patient, and they do free up a lot of patient quality of life. And humidification is not required. As I previously stated, oxygen is not being constantly pouring in to the patient's nostril. It's just breathed in as a normal intake of breath. So next we have mechanical ventilation. So this is where ventilation and oxygenation are supported by the use of a machine. These are done to support patients who are not well enough to breathe on their own. So they can be either invasive or non-invasive. So invasive meaning there's an endotracheal tube or a tracheostomy tube supporting this mechanical ventilation, or non-invasive meaning it's just a face or a simple mask supporting this mechanical ventilation. Mechanical ventilation, the settings are usually set and determined by a respiratory therapist or a physician, and these are all very patient specific. The decision to use, withhold, or withdraw mechanical ventilation must be carefully and respecting the wishes of the patient, caregiver, and family, as this is a life-saving technique or life-saving mechanism. As nurses, what do we do for a patient who has mechanical ventilation? We need to perform a respiratory assessment, integumentary assessments. So respiratory assessment is focusing on those lungs to make sure that the machine is providing appropriate support. Integumentary assessment, these patients are usually highly sedated or have a very decreased level of consciousness. So we need to ensure that we are not providing or setting the patient up for any pressure sores or any decreased or compromised skin integrity. We need to monitor the patient's sedation levels and their pain levels. Just because a patient is sedated does not mean that they don't have pain. So it is a fair balance, or it is a balance of monitoring the patient's pain and sedation levels to make sure that they are appropriate. We need to monitor the machine, and we need to correspond or respond to any alarms that the machine does give. The ideal ventilation rate is between 10 and 12 breaths per minute. So that is a little bit lower than our regular ventilation rate for you or I. So we need to make sure that we are frequently repositioning that patient. So we're alternating between prone, lateral, and supine positions. This is so we encourage the expansion of all the different lung fields and different lung lobes, but it also decreases that integumentary compromise and the risk of pressure sores. We're going to be monitoring something called the end tidal. So the end tidal is this little box-shaped rhythm seen on this photo here. The end tidal is the amount of CO2 left in the body after exhalation. So typically the target amount for end-tidal CO2 is 35 to 45 millimoles per hemoglobin. And it is this rectangular-like waveform. If the end-tidal is too high, so if it is above 45, it means ventilation is too slow and extra CO2 is building up in the patient. If the end-tidal is too low, so below 35, it means that ventilation is too fast and we don't have the appropriate CO2 building up in the patient's system. So as a nurse, we also need to be able to provide psychosocial support. So even though these patients appear to be sleeping or they're sedated or paralyzed, a lot of times these patients are aware of their surroundings. So healthcare providers are required to talk to them and address them as if they are awake and alert. Another type of ventilation is called positive pressure ventilation, or PPV is the abbreviation form. So it is a form of mechanical ventilation through a nasal or a face mask. This is done during inspiration on the machine as it pushes air into the lungs. It can be administered by an endotracheal nasotracheal tube, but most commonly through a nasal or a face mask. There are two different kinds of methods or two different kinds of ways to administer this positive pressure ventilation. We have BiPAP and we have CPAP. So BiPAP stands for bi-level positive airway pressure. And it has a set level for inspiration and expiration. Whereas CPAP stands for constant positive airway pressure. And it has a set level for inspiration and expiration together, or constant level. So I like to think of the difference between these two. As CPAP, you're driving down the highway, you stick your head out of the window and you take a deep breath in, and then you exhale with your head still outside of the window. So you're getting that constant gush of air into your face. You'll find it is a lot easier to take a deep breath in with air being forced into your face than it is to take a breath out. That is just the decrease in the ability to take a breath out is what keeps your airway open or keeps your lungs open. So it decreases the risk of a lung collapse. Whereas BiPAP, if we think of it as you're driving down the highway, you stick your head out of the window and you take a deep breath in with your head out of the window, and then you put your head back in the car and you take a breath out. And then again, you stick your head out of the window, you take a deep breath in, and then you put your head back in the car and you take a breath out. So there are two different levels for inspiration and expiration. So to use positive pressure ventilation, the patient does need to be able to have spontaneous respirations. So they need to be able to breathe independently or breathe on their own, or at least initiate some sort of respiratory pattern. There are some significant complications to mechanical ventilation. The first one being something called barotrauma, which is the rupture of the alveoli or emphysematous blebs do form. So that's what is depicted in this picture here. So we have a little bleb of the alveoli. So patients who are at risk of developing barotrauma are patients who have stiff lungs. So patients who have COPD or who have abscesses. Next complication is pneumothorax. So it's where air escapes from the alveoli and gets trapped into the pleural space, which is shown on this photo here. So we have air outside of the alveoli and is in the pleural space, which then causes the lung itself to shrink or to collapse. As a nurse, we are required to do frequent respiratory assessments in hopes to catch this when it is small. You need to notify the physician as soon as possible and prep the patient for a chest tube insertion. Next complication is pneumonia. So these typically occur 48 to 72 hours after an endotracheal tube insertion. Patients who are most at risk are patients who are malnourished, are immobile, or who have underlying diseases. So these underlying diseases could be organ failure or immunosuppressant, or on an immunosuppressant, sorry. So as a nurse, what is our role to decreasing the risk of pneumonia? We need to make sure the head of the bed stays elevated to a minimum of 30 to 45 degrees, unless it's medically contraindicated. We need to daily assess the patient's readiness for extubation. We need to use endotracheal tubes with subglottic secretion drainage. We need to perform meticulous oral care, as I've previously stated, and we need to ensure that the patient has appropriate nutrition. So these patients have appropriate enteral nutrition within 24 to 48 hours of endotracheal intubation. So excess sputum can cause some compromisations of a patient's airway. So as a nurse, we need to learn how to mobilize that sputum or how to loosen up that sputum so a patient is able to expellate it on their own. So some non-pharmacological ways that we can help mobilize or decrease the thickness of the sputum are through these four things. First one being humidification. So this is the term for adding water to long-term oxygen delivery. So just providing a little humidified oxygen. So this is necessary for any patient who receives oxygen over 5 liters per minute. It not only increases the patient's comfort, but also decreases the thickness of the sputum production. Also decreases the damage of the patient's airway. It's particularly beneficial for patients who have croup, any respiratory infections, or any sort of respiratory inflammations. As dry cilia or damaged cilia cannot function, so humidification is required in order for an appropriately functioning or a clear airway. Nebulization, which is the short-term adding of moisture or medication to air. So humidification is long-term, nebulization is short-term. So improves secretion of pulmonary secretions, and it helps moisten those cilia. Next, we have chest physiotherapy. And this is important for patients who produce greater than 30 mils of mucus a day. So chest physiotherapy is completed during using a couple of different things. So a combination of postural drainage, chest percussion, and vibration to loosen the mucus. After chest physiotherapy is complete, we encourage the patient to do a productive cough, or we may need to suction the patient in order to get that loosened mucus free and out of the patient's body. So postural drainage, so we're positioning the patient in different airways or different ways in order for the mucus to get out of the lung lobes that are affected. Chest percussion is just the rhythmic pounding on a patient's chest wall using your cupped hands in order to facilitate loosening of the mucus. And lastly, we have suctioning. So this is the used when a patient is unable to clear their own secretions. It is completed with a sterile technique as we are entering a body cavity. The frequency of suctioning is determined by the patient and by their assessment. There is a risk for the patient to desat, and there is risk for airway trauma during suctioning, so it's typically done as a last resort. Other ways we can reduce the viscosity of a patient's mucus production is through hydration. So making sure the patient remains adequately hydrated, as that decreases a thinner pulmonary secretion. Appropriate hydration in order to produce a thin pulmonary secretion is 1,500 to 2,000 mils a day. So that is recommended unless it's contraindicated by a renal or a cardiac disease. Next, we have coughing techniques. So this is encouraging the patient to expel their own secretions from both their upper and lower airway. So this is encouraged during the acute phase. So every 2 to 3 hours while the patient is sleeping, or every hour while the patient is awake. So there's 3 different techniques that we can teach a patient in order to remove those secretions on their own. So the first technique is called a cascade cough. This is where the patient takes a slow, deep breath in, and they hold it for 2 seconds, and while contracting their expiratory muscles, they open their mouth and perform a series of coughs through that exhalation. Next, we have a huff cough. So this is where the patient tries to stimulate their natural cough reflex. So while the patient is exhaling, they state the word huff, or I find a little bit more clarity for a patient who doesn't understand the word huff is to get the patient to say the word K, or the K sound. It does stimulate that natural cough reflex. And the last technique used is called a quad cough. So this technique is used for patients who do not have abdominal muscle control. So these are patients such as patients with spinal cord injuries. While the patient breathes out with their maximum effort, the patient or the nurse puts her hand inward and upward on the patient's abdominal muscles, pushing up towards the diaphragm, which then should cause or stimulate a cough. Next, we have some breathing exercises, which can improve ventilation and oxygenation. These breathing exercises are such as deep breathing, which is a slow, controlled inhalation. And we can use something called an incentive spirometer to help us with this, or to help patients visualize this. Next, we have pursed lip breathing, which is where deep inspiration happens and very slow expiration is completed through pursed lips. And this just helps prevent alveolar collapse. And lastly, we have diaphragmatic breathing, which can be a little bit more difficult to learn. The patient has to concentrate on the expansion of the diaphragm during a controlled inspiration. So this is taught by placing one hand flat below the breastbone and one hand above the waist. The other hand is 2 to 3 centimeters below the first hand. The patient is asked to inhale while the lower hand moves outward during inspiration. The patient observes for inward movement as the diaphragm ascends. So these exercises are initially taught when the patient is in a supine position, and then it is practiced while the patient sits or stands. These exercises can be used in combination. So the patient can do the diaphragmatic breathing while doing pursed lip breathing at the same time. And the last way that we promote decrease in mucus production is by the promotion of lung expansion. And this is through encouraging the patient to ambulate, encouraging different positioning changes of the patient's body, and encouraging the use of that incentive spirometer. If the patient is not able to expel the mucus on their own, they may need something called suctioning. There are a few different indications for a patient who needs suctioning. So first we have a visual assessment. So these patients are typically in a rapid or shallow breathing, or have some difficulty breathing or labored breathing. We may have some auditory sounds such as moist noises or gurgling sounds associated with their breathing. Or if we place a hand flat over the patient's chest, we may detect some vibrations from lucent secretions, which is called a tactile assessment. And lastly, we're going to auscultate. We're going to hear some coarse crackles or a loose, continuous, low-pitched rattle that continues after coughing or suctioning. That disappears after coughing or suctioning. It does not continue. There's 2 different ways that we can provide suctioning to our patient. One way through the yonker. I'm sure most of you are familiar with a yonker. This is what the dentists use, what you have used yourself while you're at the dentist, just holding it into the patient's mouth, and which allows a vacuum to suck up any sort of fluid or secretions. Next, we have a thumb controlled suction or a deep suction. So this is where a long, thin pliable tube is inserted in through the trachea and down to the bronchi. So we can perform suctioning through oral tracheal or nasal tracheal. Typically, nasotracheal is preferred as it does decrease the gag response. So this is used when a patient is unable to manage secretions on their own through coughing and they do not have an artificial airway. So the suction catheter is inserted in through the trachea, through the nose or through the mouth, and then down into the bronchi. It's completed over 15 seconds maximum. Suctioning is then applied on the withdrawal only. So these canisters or these tubings have a little hole in them at the tip where you're holding it with your hand, and it's called thumb controlled suction. So very similar to a vacuum that has a suction release valve. So when your thumb is over top of this hole, then suction comes out through the tip of the suction tubing. When your thumb is off of that hole, the suction goes through that hole where your thumb covers. So we cover that hole with our thumb as we are removing the suction tubing out of the patient. We do not cover this hole as we are inserting this tube into the patient. We only cover as we are removing it. We remove the suction tubing with suction applied in constant motion. So that constant motion is done by withdrawing the catheter, but also rotating the catheter. So we're turning our hand and removing the tube at the same time. So again, this is completed over a maximum of 15 seconds. I like to have a patient, in order to remember this 15 seconds, you can either watch the clock as you perform this, or I personally like to hold my breath as I'm inserting and suctioning a patient, as I know that when I start to get a little short of breath, that it's likely close to that 10 or that 15-second mark, as I am going to want to take another airway or another deep breath in, so likely your patient is going to as well. We're going to allow our patient to rest in between passes, and they can rest up to 2 minutes if required. The only time we will not allow the patient to rest in between passes is if they are in significant respiratory distress, and the only way to decrease that respiratory distress is to suction those secretions out. These patients may need oxygen in between passes. And we're always monitoring the patient's oxygen saturation, so we're putting a pulse oximetry on the patient as we're performing these suctioning pass. So tracheal suctioning, very similar to oral tracheal or nasotracheal suctioning, but it's just suctioning done through the tracheostomy instead. There can be some unexpected outcomes when we are suctioning a patient. The first one being dysrhythmias. So this is typically caused by hypoxia, so us just taking away their airway. So we're going to monitor the heart rate and oxygen levels during suctioning. As previously stated, we're going to put that pulse oximetry on the patient, and we are going to monitor it as we suction the patient. A dysrhythmia could also be caused by a vagal stimulation, by tracheal irritation from the suction tube. Or it could be a CNS, nervous system stimulation caused by anxiety, discomfort, or pain. To prevent, we just need to educate the patient on the procedure. We possibly need to use some non-pharmacological methods to relax the patient before suctioning. And if we suspect any dysrhythmia happening, we must stop. Another unexpected outcome is damaging the mucosa. So this is where the mucus that we expel appears to be blood-streaked. This is caused by excessive suctioning, by vigorous suctioning, or by excessive suctioning pressure. It increases the patient's risk for infection, and prevention is key. So making sure that we follow the proper suctioning protocols, the proper suctioning guidelines. So next we're going to move on to chest tubes. So care of a chest tube. So the care of the chest tube drainage system. So chest tubes are inserted to remove air from the pleural space, to prevent air or fluid from re-entering that pleural space, and to re-establish normal pressures. So the tube is inserted through the chest wall into this pleural space. The chest tube drainage system consists of a chest tube and the drainage system. There's two separate areas. It requires a sterile, airtight system to maintain the negative pressure. And the location of that chest tube depends on what we're expecting to have drain out of that pleural space. So if we are having a pneumothorax, or if we are suspecting air, then the chest tube is inserted at the second intercostal space. And the patient must be placed in semi-Fowlers or high Fowlers. This is because air is lighter than fluid, so air is likely going to rise and sit at the top of the pleural space, which is where that chest tube will need to be. Or if we have fluid, so a hemothorax, we are going to insert the chest tube at the fourth or the fifth intercostal space and position the patient in high Fowlers to suck up that hemothorax. And sorry, I said we are going to insert. We are not inserting a chest tube. A physician or someone with advanced training is inserting the chest tube. This is just an easy way to identify if the chest tube was inserted for air or fluid as one of our assessments or one of our checks if a patient has it. So the chest tube drainage system. Norquest has ones that look like this, and your textbook does talk about ones that look like this as well. So these ones have three different kinds of chambers. They have a collection chamber, a water seal chamber, and a wet or dry suction controlled chamber. So the collection chamber, the chest tube connects directly into the collection chamber. So this is the white area, and collects and measures the drainage from the pleural cavity. It is an ongoing measurement, so writing of the date on the system is required. So the patient may use these chest tube drainage systems for multiple days in a row. There is no way to empty the previously drained fluid in these chambers. So we just need to write, say at the end of our shift, the patient has 120 mils of fluid output. We would draw a line on this chest tube and put the date and the time. And then the next nurse knows that their zero or their beginning of their shift starts at 120. So if that patient at the end of their shift has 180 mils in their chest tube drainage system, they know that 180 minus 120, that patient had 60 mils of outcome on their shift. Next, we have the water seal chamber, which is the red area of these chest tube drainage systems. So this is a one-way valve that allows air to exit the pleural cavity during exhalation, but does not allow air to re-enter during inhalation. It should rise with inhalation and it should fall with exhalation. So we're going to see something called tidling. So there is a little bit of fluid in here, and we're going to see it rise and we're going to see it fall as the patient takes deep breaths in and deep breaths out. If we see that rise and that fall, that means that the chest tube is patent. If we see something called continuous bubbling, or if we see multiple bubbles in this little chamber, that indicates that there is an air leak. The higher the bubbles, the greater the air leak. And lastly, we have this area here. This is the wet or the dry suction controlled chamber, where the amount of suction a patient is on is dependent and controlled by the suction in this drainage system. So typically the amount of suction that a patient is on is -20 centimeters per water pressure. This is decreased and weaned off as the patient progresses in their chest tube journey. So this will be decreased prior to the removal of the chest tube. So to care of a patient with a chest tube, as nurses, we need to monitor the patient's respiratory assessment, and we need to monitor that patient. We need to educate and ensure that the chest tube drainage system is staying below the insertion level. We need to ensure that there are no dependent loops. So a dependent loop is where the tube goes below or above where it was previously. So on this one, we always want the tube to be going in a downward motion, as fluid cannot flow up. Fluid can only flow down. So on this chest tube here, we have this spot right here being a dependent loop, as this area of the tube is higher than this spot. So then fluid is unlikely to get pushed past here as this, and it will likely pool right here, which then can cause a growth of bacteria, which then can flow back into the patient if positioned incorrectly, which then increases the patient's risk for infection. So very careful and meticulous laying out of these chest tubes are required to ensure that there are no dependent loops. We need to make sure that all connections are sealed. So here's a connection from the tubing into the system, a connection from the chest tube to the chest tube drainage system tubing, and then a connection from the patient to the chest tube as well. We need to make sure that those are all sealed with an airtight seal. We're monitoring the chest tube drainage system itself for both tidling and bubbling. We're going to make sure that this patient has frequent ambulations and changes of positions. We're wanting this patient to use all their different lung lobes, and the best way to use all the different lung lobes are through ambulation and position changes. Encouraging the patient to take deep breaths and coughs. A lot of times patients with a chest tube, they're afraid to take a deep breath in because they have this tube sticking out of their chest. It does cause a little bit of pain and a little bit of discomfort. So these patients often need a lot of encouragement and a lot of education to take those deep breaths. And we're going to provide pain management as well. The more the patient's pain is appropriately managed, the more the patient is able to take those deep breaths and to do those coughing mechanisms or maneuvers. We're also going to provide insertion care, insertion site care. So where the insertion of the chest tube is in the patient's body, that is a wound. So we need to provide wound care to that insertion site. There are new chest tube drainage systems that are out and seen in the Edmonton area. These chest tube drainage systems are called the Topaz, and they're electronic chest tube drainage systems, and they are beautiful. So we no longer need to, with a chest tube drainage system such as a Topaz, we no longer need to worry about dependent loops. We no longer need to worry if the chest tube drainage system is below the chest tube site, as it is all mechanical suction powered. These drainage systems have these little electronic screens that tell us exactly how much of an air leak is present in the system, how much fluid is built up and expelled out of the patient's chest, and the suction power of this drainage system. So these are currently not reflected in your textbook, and Norquest is currently not teaching to these Topaz chest drainage systems, but they are possibly something that you are going to see in your clinicals, as well as definitely something you are going to see after you are done school, and something you're going to need to get familiar with once completing your LPN. So how do we care for a patient who has altered oxygenation? There are two main different kinds of lung disorders. We have obstructive lung disorders and restrictive lung disorders. Obstructive lung disorders are the most common chronic condition. These are caused by an increased airflow resistance as a result of an airway obstruction or narrowing. These include but are not limited to COPD, so chronic bronchitis or emphysema, cystic fibrosis, and asthma. These are commonly diagnosed through a chest x-ray, pulmonary function test study, allergy test, sputum cultures, or an ABG collection, so the arterial blood gas. So patients with obstructive lung disorders are typically found with these sorts of assessments. So they typically do something called tripod breathing. So breathing leaning forward. They do pursed lip breathing. They typically use their accessory muscles to help breathe or to get that airway open. They typically have an extreme or excess amount of sputum production. They can be tachypnic, so have an increased breathing rate. They can have an increased anterior-posterior diameter. So this is if they have had an obstructive lung disease for many years. They typically develop an increased anterior-posterior diameter. So if you guys remember through HEES, the regular anterior-posterior diameter is 1 to 2. So these patients are typically seen with a 1-to-1 ratio. They can have clubbing of the fingers. They can have some cyanosis in severe cases. And they can have some adventitious breath sounds such as crackles, wheezes, and stridor. So how do we manage a patient with an obstructive lung disease? This is managed through a combination of non-pharmacological and pharmacological matters. So non-pharmacologically, we can encourage deep breathing and coughing, educate the patient on preventing any lung infections. They may need a low amount of oxygenation. They may need help promoting the clearance of secretions. We need to encourage that they are receiving the proper nutrients. They may need lung transplant. You may have to perform something called chest physiotherapy, which I've previously talked about. Encourage aerobic exercise, not anaerobic, aerobic exercises. We need to educate and encourage smoking cessation. A lot of obstructive lung diseases, specifically COPD, are caused by patients who are long-term smokers. So encourage the cessation of smoking. Humidification or nebulization of the airway as well, in addition to pharmacological matters, such as giving bronchodilators, corticosteroids, antibiotics, or nutritional supplements. And next we have restrictive lung diseases. So this is caused by a decrease in the total volume of air that the lungs are able to hold. This is often due to a decrease in the elasticity of the lungs themselves, or caused by a problem related to the lung expansion of the chest wall during inhalation. So restrictive lung diseases include, but are not limited to, atelectasis, pulmonary edema, pleural effusion or hemothorax, pneumothorax, pneumonia, ARDS, which we'll talk about later in this slide, or in this presentation, obesity, and cancer. These are diagnosed through chest CT and chest x-rays. So we'll typically find these patients also sitting in the tripod position, so leaning forward, trying to open up those airways naturally. They may be splinting. They may be hypoventilating because they are not able to take deep breaths in if they find it quite painful. They might also be tachypnic. They may have some tracheal deviation that is more specific to a hemo or a pneumothorax. They may have some altered tactile fremitus. They have asymmetrical chest movements. They also have some adventitious lung sounds similar to that of an obstructive lung disease, but these would also include a pleural rub. and they may have some absent lung sounds. So this chest x-ray here shows a left pneumothorax and a left tracheal deviation, so a shift to the right. So how do we manage a patient with restrictive lung diseases? Again, it's a combination of numerous different things, so non-pharmacological, pharmacological treatments. So deep breathing and coughing, education on preventing of lung infections, give and provide oxygen, encourage rest, encourage fluid intake of 3 liters per day if not contraindicated, 150 mccal per day oral intake, and encourage frequent positioning changes. Pharmacologically, we can provide potential antibiotic therapy if applicable, or antiviral therapy. We can administer antipyretics and pain management. And treatment, typically we will want to treat the underlying disease or whatever disease is causing a restriction in that lung. We may provide something called a thoracentesis or a chest tube. So a thoracentesis is the insertion of a needle into the lower area of the lung fields to remove fluid. So acute respiratory failure. This is not a disease itself, but is something that results from other diseases on the lungs or something resulting from a disease of another body system. So there's 2 different kinds of classifications. There's hypoxic or hypercapnic. You're going to go into more detail regarding acute respiratory failure in your pathology. So acute respiratory failure is diagnosed with an ABG, a chest x-ray or CT, or pulse oximetry. With ARF, we typically find patients who are tachypnic, who have low heart rates, or low breathing rates, who hypoventilate. They tend to speak in short, clipped sentences. They use their accessory muscles when breathing. They have adventitious or absent breath sounds. They can have tachycardia. They're often quite confused or they're agitated. So just a fun fact that's actually not really fun at all. Most children who go into cardiac arrest are not actually because of a failed cardiac system, but it's typically because of a failed respiratory system. This is why in your CPR class, they tell you to call 911 first before starting compressions. Whereas with an adult, you tend to start compressions before you call 911. An adult is more likely to have a cardiac arrest due to a failed cardiac system than a failed respiratory system. So how do we manage someone with ARF? We ensure that their head of bed is positioned to at least 45 degrees. This maximizes the thoracic expansion, which then increases the ventilation and perfusion of air to the lung bases. It reduces abdominal pressure on the diaphragm as well. We need to prevent, so using appropriate treatment of underlying diseases in relation to respiratory failure. We can provide positive pressure ventilation, so PPV, so that is BiPAP or CPAP that we previously talked about. And encourage the mobilization of secretions through coughing, suctioning, and chest physiotherapy. Next, we have ARDS, or acute respiratory distress syndrome, which is a sudden progressive respiratory failure where the alveoli fill with fluid. So this is diagnosed through a chest x-ray. The mortality rate for ARDS is 50%. A few years ago, when COVID-19 was new and spreading quite rapidly, we had a lot of deaths related to COVID-19. COVID-19 was not actually what was causing the deaths in the patients. These patients were dying because of ARDS, or acute respiratory distress syndrome, which was triggered by the COVID-19 virus. So patients with acute respiratory distress syndrome initially appear to have dyspnea, tachypnea, cough. They tend to be a little bit restless, and they have crackles on auscultation. but then they very quickly progress into these more advanced assessment findings. So severe dyspnea, severe tachypnea, hypoxemia, intercostal and substernal retractions, so the use of the accessory muscles. They tend to be quite diaphoretic. They have a great decrease in their mentation. On auscultation, you're going to hear diffuse crackles or wheezes throughout all of their lung lobes. How do we manage someone with acute respiratory distress syndrome? We just need to treat the underlying cause. Other than that, we can provide, again, non-pharmacological and pharmacological therapies. So non-pharmacological, we can provide oxygen or PPV, position the patient in the prone position, which allows for more airway expansion. We can provide high frequency oscillation, which is chest physiotherapy, essentially. We can provide lateral rotation therapy, which is encouraging a slow side-to-side turning of the patient. Just decreases that fluid from pooling in one area of the lungs. Pharmacologically, we can provide diuretics, administer dopamine, a vasopressor, and provide IV fluids. So this is a chest x-ray of a patient who is in acute respiratory distress syndrome. So as previously stated, all of these little white spots are consolidation. So all of these white spots in the patient lungs, this is fluid consolidation. So if you go back 50 slides on the previous chest x-ray slide that I showed with a patient who had very clear lungs visible, you see a great difference between this x-ray and that x-ray. So patient-centered care. So it's very important for patients who have respiratory or ventilation abnormalities to involve family, as it increases the patient's well-being, provides a more personal level of care, advises and the decision maker when the patient is unable to. So that is when we have something called the power of attorney take over care of that patient. Family may be able to help the patient with ADLs, which increases the patient's sense of well-being. It can help decrease risk factors, so they may help the patient stop smoking or may help decrease allergens. Consider traditional healing practices. So other cultures have different kinds of healing practices that they do use. Encourage family presence during invasive procedures. So research has found that if a family member is present during invasive procedures such as intubation or thoracentesis or even CPR, that these patients have a higher risk or a better outcome. This also decreases any caregiver's doubts, anxieties, or fear about the patient's condition and that they are appropriately cared for. And lastly, a big part of treating a patient with altered oxygenation is health promotion and education in reducing the risk of complications. So a lot of that education revolves around behavior changes. So smoking cessation, encouraging an adequate nutrition or hydration, encouraging exercise, encouraging vaccinations, reducing outdoor activity when it is cold if they have any sort of pulmonary compromise, limiting both caffeine and alcoholic beverages, use of filtration masks if they're exposed to any sort of inhalation chemical or pollutants, and lastly, the use of deep breathing techniques. And that is the last